causing severe obstruction eventually to the point where they're going to require some type of bypass surgery. So we know on laryngoscopy we're going to see all these things related to the brachycephalic syndrome, but we can see one more thing, and that is laryngeal collapse. And if you see laryngeal collapse, I'll show you an example of that in just a little bit, then if it's severe enough, in most cases, doing surgery on the soft palate, the stenotic nares, the saccules won't do any good. So, what about tracheostomy tube placement? Well, there's a couple indications time-wise. One is if you preoperatively, if you have a very fat, obese English bulldog that's got severe upper airway obstruction, and you know that surgical trauma during the soft palate resection, the stenotic nares, but mostly the trauma in the oropharyngeal area is so severe that following surgery, the swelling and the inflammation is going to be compromising this patient and possibly lead to its death as it's trying to recover from your surgery. So we may decide to actually put a tracheostomy tube in before surgery. That's rare. Most of the time I wait till I do the surgery and see how much compromise there is in the oropharyngeal area. And so I oftentimes will wait and do it afterwards, okay, post-operatively. But here's one of the advantages of placing a tracheostomy tube. First of all, it makes their waking up much safer. Now, if you're doing stenotic nares and elongated soft palate, for example, on Boston Terriers, French Bulldogs, Pugs, generally speaking, they're a lower risk with respect to airway obstruction after surgery from all the swelling. It's the really overweight English Bulldog that is a very high risk. One of the advantages of the tracheostomy tube before surgery is that you're going to have it in after surgery, and usually it only has to be in place for 1 day before you can pull it. So you just need to get through the swelling. We give them corticosteroids to help fight and counteract the swelling and inflammation at the time of surgery. But here's another advantage to placing a tracheostomy tube before surgery. A tracheostomy tube can come with or without a cuff. If you place a tracheostomy tube with a cuff, which I'll show you an example of, then you can do your anesthesia through this, okay? You don't have to put an endotracheal tube in. And what does that mean? That means that your visibility in the oral cavity is amazing because the endotracheal tube is not in the way. You can see the saccules. You can do your surgery on the soft palate. All of this with really good visualization, okay, visibility. So that's another advantage. Keep in mind, if you are, let's say, doing surgery on a tumor in the oropharyngeal area, is another example, or there's a big abscess there, or something that's very difficult to access surgically, again, a tracheostomy tube is a perfect way to give you a lot of room, open the mouth up, get good vision of exactly what the pathology is, do your surgery, and again, because you've been doing surgical trauma in that area, the trach tube is in place. Leave it in for 24 hours. Make sure, at least 24 hours, make sure that the animal recovers well. And it's amazing when you see some of these dogs really struggle after your surgery to put a trach tube in after surgery if they're in trouble, or you decide during surgery you better put one in. It's amazing how well they do with just allowing that area you've done surgery in just not be challenged, not attempting to breathe, very little trauma. They're breathing nicely through the trach tube. You're watching him throughout the 24-hour period. Then there's a technique where you can see if they're going to be okay to pull the trach tube. But it's really a wonderful thing to have to make some of your surgeries go very safely post-operatively. Okay, so as I mentioned before, many of these dogs, sometimes I make the decision, most of the time I put it in post-operatively because I wait and see what surgery is done, how much obstruction there is, how much collapse of the larynx there is, if there's a little bit of collapse. So then I make the judgment. So I do the surgery, then I put the trach tube in, or sometimes I'll put it in before surgery. Okay, so we do the staphylectomy, the soft palate disease. Okay, there's other indications for the tracheostomy tube. Okay, trauma to the laryngeal area. Sometimes a big dog gets a hold of a small dog and there's a lot of swelling, and we need to actually place a tracheostomy tube in order for all that swelling to go down. Again, I mentioned this to allow excellent surgical exposure of the oral pharyngeal area, or rarely we'll have to do this in some cases to place an animal on a ventilator for various periods of time, and that requires a cuffed type of tracheostomy tube. So the ventilator support is rare. Usually we just do that at the university. We had a dog at the university that was on ventilator support for 2 weeks, and if you can imagine how much money that costs, because it's in our intensive care unit and it's very expensive. Okay, so we have various ways that we can actually access to get into the lumen of the trachea, but the incision that I want to encourage you to use is one that goes between the rings. And we will start anywhere from between the 3rd to 4th ring all the way back to maybe the 8th and 9th ring. So once the incision is made, we place sutures. You'll see this in more detail. The trach tube is put in. Then we use one of the things I like to use here is umbilical tape, but you could use shoestring, okay? Get a shoestring, just use that to tie. You'll see on a video how I do this. Okay, as I mentioned before, it can be cuffed. The nice thing is you can insufflate the cuff if you put them on a ventilator, or you use this as a means of giving gas anesthesia. Okay, so the cuff type is fine. Most of the time when I place a tracheostomy tube in, it doesn't have a cuff because I'm just using it to allow the swelling and inflammation to recede, and then I pull it usually within 24 hours. Okay, again, it's a cuff or non-cuff. Now this is very, very important. The tracheostomy tube that you choose to put in should be undersized. It should be a little smaller in diameter than the trachea itself. Okay? The reason for that is because if that tracheostomy, two reasons. One is if that tracheostomy tube becomes obstructed with mucus or blood, even though we're taking periods of flushing, they can still breathe around it and give you time to take the tube out temporarily and clean it and put it back in. So it helps prevent what we call silent death from the tube becoming occluded. We know that when the tube is present in the trachea, there's a lot of excess mucus being produced, and that's going to obstruct the tube. And again, occlusion is the most serious complication in the dog and the cat. Usually about 20% of the dogs will have some degree of occlusion. That's that means 1 out of 5. That means after we place a trach tube, we need to really take care to keep it suction free. And cats really, really are crazy with the amount of mucus they produce. And they are at very high risk, not only for trach tubes, but performing a permanent tracheostomy. So they're much more difficult to manage. You can see this trach tube, a couple of them here. This is a endotracheal tube that was used as a trach tube. And this is an old stainless steel tracheostomy tube. You can see how it's filled up with this material. This is, here we have, on one hand we have a life-saving method, okay, placing a tracheostomy tube. And on the other hand, it can lead to death. So you can be successful with a trach tube, or they can die. So you can live and die with a trach tube. And so proper care of the trach tube will help decrease this problem. Okay, notice how much smaller this is than the diameter of the trachea. This is very, very important, okay, that it be a little bit smaller than the diameter of the trachea. Why is that? I told you before, if this occludes with mucus and blood, then they can still breathe around it, hopefully. Secondly, how do you know when to pull the tube? How do you know when to pull the tracheostomy tube? Well, it's in, you're taking care to suction it, keep it clean. The next day, you think, well, let's see if we can pull the tube. And so what you do is you basically put your finger, okay, on the end of the tube, and if they can breathe around this, or maybe through the tube, if they can breathe around it without any effort, then you know it's okay to pull the tube. If you place your finger on this, and as you have your finger on this, the dog's okay for about 3 or 4 breaths, but then eventually there's just too much swelling, okay, still up here, because right now what you're doing is when you put your finger on this, now the air is coming from in the oral cavity through the larynx and down. So if they start struggling, then you know you have to leave that tube in another day, okay? Now notice the technique includes sutures placed through the ring above and below where your tracheotomy incision is, okay? And the reason for that is because if this obstructs, you need to be able to go to that animal, and usually without tranquilization or possibly a tiny little bit of tranquilization, pull the tube, clean it out, and put it back in. And those 2 sutures are important to allow you to put the tube in and out easily. Okay, so there are various types of trach tubes. I really like the type that has what we call the inner cannula. That just means that I can pull it out and clean it. This stays in, and this goes inside that. This is an obturator. We use that to put in this. So this is our main tracheostomy tube here. But then it has a cuff up here, or a neck, that allows me to put this in, and that then, because it's got a rounded, allows you to put it in the tracheostomy incision easier. Then you take that out and you put this one in, and that clicks into place, and then you can leave this in, but you take this out and you clean it every 4 to 6 hours. So it's really nice to have that inner sleeve or inner cannula. Now, I'm not sure if you have access to Shiley. I'm not sure what kind of trach tubes they have here at Eickemeyer, but we're going to find out. Here's the obturator, as I said before. You just stick it in here. It clicks, snaps into place. You place the tube, then you take that out, and you replace it. Okay, so this helps you put it in the trach incision. Then you pull that out, and you take the sleeve and put it in, and that snaps into place. Then that's what you take out to clean, okay, every 4 to 6 hours. And there it is in place, and then we're going to put a string around it. Okay, so the tube care, as I mentioned, is very important. Suction of the airway every 4 to 6 hours. Then, if a dog weighs 10 kilograms, he should have 2 milliliters of saline sprayed into the tube. So this saline spray is actually sprayed into the end of this tube. So you take, let's say, a 10-kilo dog, you take 2 milliliters of saline, and you put it in a syringe, and you take a 25 gauge needle, and you stick that up in the opening, and you spray it in, okay, with a little bit of force. You don't suction it back out, you just spray it in. That keeps the environment in the tube and a little bit of the trachea wet and humid, which means there's less chance of the mucus forming a solid, okay, plug. So that's very important to do besides suctioning, okay? Or if it has a removal cannula, like I showed you before, then you can take it out, put it in some chlorhexidine antiseptic material solution, clean it out, and then put it right back in. Okay, as a member, I mentioned most cannulations, most of the time, the use of this is only necessary for hours to 1 or 2 days. So that's nice, okay? Really, in most cases, does not need. So that means then the management and the care of it, it's not too terribly difficult. You have to clean it, suction it out about 4 times a day, 4 to 5 times a day. Okay, so again, put your finger to remove, as we mentioned before, put your finger on there, leave it on. If they're breathing okay for 3 to 4, 5 minutes with your finger on this, then it's okay to remove it. Once you remove it, then you take these sutures out and you do nothing, okay, except keep the wound clean. You don't try to close it, you just let it fill in on its own, okay? Okay, now what about a permanent tracheostomy? That's our next step. Let's see here. Yes? Yes, you always have a question. Let me introduce you to Laszlo, who's from Schmidt, Germany, and he always asks questions. I have usually, for every 10 minutes of lecture, I have 10 minutes of answering his questions. Which I do enjoy. Yes.
You have to handle it very quickly.
Yes.
You don't know any narcosis, and you can make a tracheostomy.
An incision.
Incision.
Yeah.
Only sedation. If it's an emergency.
Unfortunately,
case.
yeah.
Or you do that, or you put some anesthesia before.
I almost always put anesthesia, but it means accessing a vein, and this animal's trying to die. Everybody understand this question because it's a really good question. Everybody understand? Because I may need Freddie to help. Okay, so the animal comes in, it's dying, and you have to access the trachea immediately. Okay, that's a great question. That's one of the best questions you ever asked. What would you do? What would you do? There's an easy answer. What does that mean? I don't know.
I've seen it before. The cat was dying, and surgeon cut it open, put it in.
Yeah, yeah. It can be done very quickly if you've done it a number of times. And when the dog's, gasping for his breath, you could do a local anesthetic, make a small incision, and pop it in. An alternative would be to sit here as I'm talking, and you can feel the soft spot right here, the cricothyroid membrane. Cricothyroid, dogs have that too, okay? So you could take a 14 gauge hypodermic needle, pop it right in there, just pop it right in, okay? And that will give you time, put some oxygen close by, and that will actually get around the airway enough, in most cases, if everything's obstructed above that is. And most of the time it is. So that's one way you can get around it. 14, 12 gauge, big size, just pop it in. That'll be life-saving. Then he'll have oxygen through that. Put some oxygen right on that. And then give him, and there you go, okay? Because there's really no other way quickly to do it other than the what he said. These dogs oftentimes are collapsed and maybe are so cyanotic that brain-wise, you could just do a local and immediately go in there and cut out, put a regular trach tube in. But in a real emergency, you just pop a really large hypodermic needle in there, and that'll buy you 5 minutes. Okay, it's a good question. I mean, for you. Okay, so what about a permanent tracheostomy? Well, this is a really wonderful procedure to have available. We consider it a salvage procedure for Stainsey. Salvage, the last resort. The only thing left to do to save this animal's life. Everything above that is totally destroyed. You have no alternative. You can't leave a tracheostomy tube in forever. The dog's probably going to eventually die, or cat, from it, because it's going to be such a management problem. And so you need to have something that you can use to bypass that area. And it's, you know people that have had laryngeal neoplasia, heavy smokers, have had to have their laryngeal apparatus removed, and the only alternative is to make a permanent opening in the trachea. Well, the same thing applies to the dog. Let me be very quick to add that doing a permanent tracheostomy in a cat is really loaded with lots of complications after surgery. Cats do not tolerate permanent tracheostomies very well, okay? They just don't. So, let's talk about indications. Well, chronic airway obstruction, whether it's the brachycephalic or others, like let's say a Labrador Retriever with really, really severe laryngeal paralysis. The larynx is collapsed. The surgery we use on them won't work because the larynx is, the cartilage is so collapsed and very soft. So if you were to try to pull a portion of the arytenoid cartilage over in a tie-back procedure, it's not going to work, because the rest of the larynx will just collapse over it. So chronic airway obstruction resulting in laryngeal collapse, laryngeal masses where you will go in surgically, remove them, but there's no way you can restore or reconstruct the larynx, so you have to bypass it. I already mentioned possible laryngeal paralysis, severe. Irreversible trauma, maybe bite wounds to the neck area, and perhaps during the bite, both of the recurrent laryngeal nerves have been damaged. And so now the trauma, or I should say the ability of the larynx to function is gone. So you'll have to bypass it with a permanent tracheostomy. Or similar to what the laryngeal mass, if you have resection and reconstruction, there's just no way you can do it successfully, so you have to then go further down and do a permanent tracheostomy. Here's a good example of laryngeal collapse. You can see this often with chronic brachycephalic syndrome. Here you see some other examples of severe end-stage laryngeal collapse. This is really a lot of redundant pharyngeal folds. This is the arytenoids that are folding over each other. So this is a really good indication. I probably do most of my permanent tracheostomies on pugs, actually, with upper airway problems, brachycephalic, because pugs tend to end up like this often, and any brachycephalic surgery we do really won't work, so we need to bypass it and do permanent tracheostomy. Now, it's very important that you understand and keep in mind that don't just focus on larynx, okay? You need to also know that there are some instances where not only do these animals have laryngeal difficulties, but it may be a breed that has tracheal collapse as well. So if you do a tracheostomy here, it could be that the tracheal collapse further down is going to still be a problem. So you need to assess these patients very, very carefully. Make sure that you do a thorough evaluation and let the owners know that you can bypass the larynx and put a tracheostomy opening here, permanent. But further down, if it's a little poodle or some of the other terrier breeds, they get Pomeranians and other terriers and some terrier breeds, that further down the tracheal collapse may be so severe that even though you're doing a permanent tracheostomy, it may be okay for a few months. Remember, once an animal has tracheal collapse, it's progressive. And not only is the trachea get involved, but eventually the bronchioles. Okay, so the primary, secondary bronchioles are going to start collapsing too. So make sure the owners understand if this dog has concurrent tracheal collapse, that this only work for a short time. Otherwise, it works for a long time. Okay. So it's a fairly straightforward. Sorry. Yeah.
How do you know? Can you know in advance if the permanent tracheostomy doesn't work? Also with the tracheal collapse, do you know in advance if it's possible or isn't? Is it going to work when the tracheal collapse is too bad?
Yep. So, okay, ask the question in German.
German is easy.
Oh, you don't know German.
Difficult.
Oh. Okay, do you know what he's asking? Ask me again.
Whether you know in advance.
And do you know in advance if the tracheal collapse is going to be
A problem.
A problem
No.
afterwards? Is that possible to know in advance?
Not
X-ray
the
or
only.
you hope that it works.
Okay, can you ask the question so everybody in German so everybody understands?
Ja, ob man vorher abschätzen kann, ob der Trachealkollaps so gravierend ist, dass die Tracheostomie mittelfristig nichts mehr bringt oder langfristig.
Okay, so these are the primary stem bronchi. Here's the trachea. And the question is a really good question. Can you know in advance? I can know in advance anatomically. So to answer your question, if this dog does have and requires a permanent tracheostomy because it has disease up here, which incidentally, again, the pug seems to be the one that I need that has all the problems here and a tracheal collapse. That particular breed, in my experience. Doesn't mean that that's the way it is. It can be other breeds. So, if this dog has tracheal collapse in addition to laryngeal collapse, the tracheal collapse is a completely different disease, but it needs to be addressed. So what I would do in that situation is to attempt to do endoscopy. You can do orthogonal radiographs, okay? You can do fluoroscopy, which in your practice and my situation is not practical. There's really only one sure way to confirm. You can do thoracic radiographs, and yet thoracic radiographs can give you false positives. It can show you what you think is collapse, but it's just that you hit them in a phase of their respiratory cycle where it doesn't really show you. It's not a true anatomical depiction of what's going on. The only really good way to diagnose tracheal collapse and how severe it is to do endoscopy. So you have to do tracheoscopy. You have to go all the way down, look at them, and if those are collapsed, then the chances are that if you do a permanent tracheostomy, not going to do much good. And I think that's a really good question because this may help for 1 to 2 months, maybe, or not at all, or very little. So really the only way, because you know, here's, so there's four grades of tracheal collapse. Grade one just means there's a little bit of, so this part right here, from here to here, is a trachealis membrane, okay? And so that collapses a little bit. Then as we get further along, some of this membrane will drop down. Plus this part of the cartilage is no longer like this, it's more like this, okay? So it gets flatter, the trachealis membrane in 3 and then 4. So that's why doing tracheoscopy and bronchoscopy is so important, so that you can grade this. And if you have a grade 3 or 4, either alone or in combination with the main stem bronchi, when you see them that they're collapsing as well, it's not a good idea, okay? Probably not a good idea. Again, this is probably 10% of our patients that we're going to do tracheostomy tubes on, or tracheostomies permanent. So it's a very low percentage. But it's just important to think of everything that's going on before you make a recommendation for what's best for that particular dog or cat. I pretty much almost now in cats, even if they're really severe and need a permanent tracheostomy, I almost always don't do it because it puts the cat through a lot. There's a lot of post-operative management and a very, very high rate of death, okay? So it's really, really, really difficult to talk me into wanting to do a permanent tracheostomy in a cat. Very, very seldom.
What do you do?
Basically nothing. I mean, just, yeah, I mean, try if it's possible to medically treat them, which it isn't. Keeping in mind that while that may seem a very cruel decision, the fact is you're putting this cat through this procedure, you're giving the owners this hope that maybe it'll help, and a very small percentage will these cats. Most of them are within 5 to 7 days are dead because of the clot formation in mucus. They just do not tolerate it well. Now, to go back to your question, which is a really good question, what if this is a whole another topic, but I can tell you that we do this on occasion. Let's say that here's the trachea again, cricoid. We do a permanent tracheostomy here, okay? And our collapse, the collapse of the trachea, here's the thoracic inlet, okay? So here's the cervical trachea, and this is the beginning of the thoracic trachea from here to the diaphragm, or to the lungs, okay? Sometimes what we'll do is if there's collapse next to where the tracheostomy site is, we'll put the external rings, okay, on the outside. I've done that on a few cases because the collapse is limited to right here. So again, it's a completely different topic, different lecture. I don't want to go into it, but it really would, it's very easily corrected by, here's the trachea, putting external rings on that you've seen, I'm sure, described. You'd probably put 1 or 2 here, 1 or 2 here, and these are sutured to the trachea, mostly the dorsal aspect, because that's where the trachealis membrane is. So it's just pulled up, and it keeps that portion of the trachea enlarged. So to answer your questions, if it's limited to just the cervical area, we've determined that with tracheoscopy, then we can put these external rings on, okay, outside the trachea, and pull it so it keeps it open. Have you ever done that, Freddie? Put the rings with, yeah. Again, it's very rare that you would do that.
What's about stenting?
Yeah, I think this would, if it's just in the cervical area, you could do stenting. But the rings in this area have shown to be just as effective as stenting. So if I'm there and I'm doing a permanent tracheostomy, I don't know about stenting through that site. It's probably not a good idea to put a stent right through there. So, and it's extremely expensive compared to the rings. There's been some recent studies done. You all know about tracheal stenting, and there's been some recent studies done that actually show that these external rings are just as effective now. We used to think that the stenting was the best. It's definitely quicker and easier to place, but the ultimate results at the end are about the same as the external rings now. So.
And the rings, you can do it from syringe?
You can buy them commercially. Most of the people that are doing this prefer the commercially available ring because they're a little easier to work with for the surgeon.
What material is the ring?
I don't know what the material is. It's probably some sort of polyethylene, but it's not as hard as a syringe case. It's actually softer and easier to use, and you can buy them commercially. I can actually look up, if you want, where you can get them. Okay, so the permanent tracheostomy, even though we talk about exposing the trachea, if you do destroy the laryngeal nerves, you're really not going to get close to them. But you know, if you're doing a permanent tracheostomy and you affect one of the recurrent laryngeal nerves, cut it or damage it, doesn't matter, because you've got a permanent tracheostomy. So they don't really need to we still try to be careful. Okay, now another reason for being really careful that you don't destroy the laryngeal nerves, you would really, really, really have to be a terrible surgeon when you're doing a permanent tracheostomy to involve the recurrent laryngeal nerves. They're too far dorsally. They're out of your surgical site. But you still want to preserve them if they're there, because occasionally a permanent tracheostomy site, believe it or not, will actually heal completely over. I've had some dogs, English Bulldog in particular, where it completely healed over. This dog lost weight from 70 pounds to 50 pounds. Okay, so 33 kilogram, okay, down to about 23 kilograms. So that's a lot of weight loss. Over the time that he was losing weight, his permanent tracheostomy came down to be pinhead size, maybe the end size of the end of this pin. And then eventually, a couple months later, he comes back and it's completely closed over. Well, if I would have destroyed the recurrent laryngeal nerve, his larynx wouldn't have been able to work, and he wouldn't be able to breathe. So be careful. Rarely, but it will happen, that when you do a permanent tracheostomy, even though you do it exactly like I'm going to describe it, occasionally they'll heal over, which is really crazy when you think about it, but it does. Okay, I'm going to show you a video that leaves this step out, but I'm going to show you what we mean by that. As you take the sternohiatus muscle and you bring it up dorsally to the trachea, and that helps push the trachea ventrally. Now, you are going to see in the textbooks, and you're going to see the picture in your notes, where it's a rectangular incision, where you're actually cutting out about 3 rings, and you're making a rectangular incision. And it has been shown in people that when permanent tracheostomies are done, it's probably better to make an oval incision. The chances of the oval incision healing back together is less. than if you do a triangular. Okay, I don't know why. It's just the experience of our counterpart human surgeons. So that's what we're going to do today. So what we do is we take a segment of the trachea, and what I like to do in the lab part is actually have 2 tracheostomies done. Okay, we'll do a tracheostomy tube placement, and then we'll do 2 permanent tracheostomies. So the first tracheostomy that we'll do, the tube placement of the tracheal tube, the trach tube, tracheostomy tube, let's do maybe between 3 and 4 rings. So we'll make our incision there, put our trach tube in, and put it in place, and then stop. And what we're going to do is we're going to make a very small incision. On the video, I show a large incision. You only want to make a small incision for the trach tube placement, okay? You don't have to make it. Then, once the trach tube is in place, we'll take it out. Then we're going to remove a section of the trachea here, and then another surgeon will do one down here, okay? So when we start the permanent tracheostomy, what we want to do is place a mattress suture from one sternohyoideus around the top of the trachea, and then through, and then back. And then that takes the muscle, you can see here, and when the muscle comes in, the trachea moves a little bit ventrally. Makes it a little easier for you to be exposed. And this is another thing now that you will see in textbooks, and take it from me because I've done a lot of permanent tracheostomies. Textbooks will show you to make an incision like this, peel the cartilage back, okay, and then expose the lining, the respiratory epithelium. And I can tell you that is nearly impossible to do, because as you're trying to separate the cartilage from the lining of the trachea, the lining of the trachea will tear, it will form holes. I don't do that at all, okay? I don't know many people. The textbooks show it. So textbook after textbook, year after year after year, shows this, but very few surgeons can do it nor want to do it. So you don't have to do that, okay? Make it easy. It's not necessary. And this is what they're showing. They're actually showing you the lining of the trachea being sutured to the skin. And this is impossible. It's very difficult for me to do in most surgeons. So we don't do that. We just cut a piece out and suture the skin back to the trachea. Okay, as again, complications. Well, mucus plugs, similar to tube tracheostomy. Okay, so we have to suction, okay, again, every 4 to 6 hours, usually very intense for the first 2 or 3 days. This is actually when cats will die because they have so much mucus and blood that forms, and we just can't keep up with it. They form a mucus plug, and they die just like that, okay? Stenosis. This is weeks, months after the surgery. Sometimes it can actually become really so small from stenosis. This is, again, pretty rare. Or it may completely heal over. Cats, as I mentioned before, do really poorly. One of the things I want to go back, so I want to digress for a minute. One of the things I want to really stress to you in your counseling with people that have brachycephalic dogs or any other dogs that have upper airway disease. If these animals are overweight, if they are obese, if they are fat, it's amazing how weight loss really helps these animals. And a good example is what I just told you. I had this 70-pound English bulldog that required me to do brachycephalic surgery. It then had laryngeal collapse. I then had to do tracheostomy permanent. That tracheostomy tube healed over, and 20 pounds that he lost. Now that extra weight allows him to breathe normally because the tracheostomy tube closed over. So I cannot emphasize enough, whether it be a French bulldog or a pug or an English bulldog, that if it's obese, they do so much better with airway disease, upper airway obstruction. Even if you can medically treat them and they lose weight, they will do so much better with that weight loss. So much better with much less weight. And maybe it won't even require surgery. This is a dog that had laryngeal paralysis and got so severe that it had obstruction. By the time we could do surgery, it wasn't possible because the cartilage in the larynx was too soft. And so you can see it's a permanent tracheostomy. So the first few days after performing this, it's really intense. It requires a lot of post-operative care, of suctioning. Again, you do the same thing here. You take the saline in a syringe, the same amount, 0.2 mils per kg, and you put it just outside the opening and you spray it in to keep the trachea moist. So any plugs that form, you try to keep the plug from getting too solid, forming a solid plug. This dog also had other problems, but that just shows you what a mature tracheostomy looks like, and this is probably, well, the other thing is you can see here, it's very important that the people, once it discharged from the hospital, that they keep an area that's clipped around it, because even after surgery, several months, there's a small amount of fluid that'll form. It's very low viscosity fluid. It's not really thick, but it could be catching in the hair and possibly cause obstruction of that opening. So we like to keep this area clipped. And if this animal used to like to swim, obviously no more swimming, okay? Okay, let's go over this. Not going to be able to do this in lab, but here is just a really quick, simple thing. If there is something in the trachea and there's a segment and a bite wound from another dog causing trauma to the trachea is probably the strongest indication we have, and maybe there's an area of stenosis following a tracheostomy or following trauma. The trachea is fine, you send the dog home. 3 months later, the trachea where the dog bite was has now formed scar tissue, and you can think about cutting that area out. The area of the trachea has approximately 35 C-shaped rings in the dog. Approximately 20 to 40% can be removed. This is really, really stretching it. That's really tough. I'd say this is probably closer to the figure that I'm more comfortable with. So, 6 to 7 rings. So obviously now it's really, really important that when you take that segment of trachea that you're going to resect, that you preserve the blood supply. Whoops. So when you're dissecting around the trachea, you stay right down on the trachea, preserve the blood supply. You'd free up the recurrent laryngeal nerve and gently pull it away from where you're going to be cutting out that segment of trachea. We place stay sutures above below. Pre-place the breaking, I'll show you here in just a minute, and then after we get completely done with our simple interrupted sutures, we then place tension relieving sutures. Here's what I mean by that. Here's your stay suture here and here. Okay, that's to help you manipulate it. The recurrent laryngeal nerve along here, as well as the blood supply, is gently pulled away all around 360 degrees. So these stay sutures are in place. The area of the trachea is now resected. And now what happens is you want to pre-place. Everybody understand pre-place? 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 Understand? Say it. Okay. The trachealis. So the first sutures we put in are the trachealis membrane. So we're going to go deep, and we're going to place it in such a way. You can see how this suture goes. It goes so that we pre-place it so that we can place these accurately. And then at the end of placing them, then we tie them. And notice how we place the suture. It's going from the outside to the inside, inside to the outside, outside. So we're doing it in a reverse fashion so that when we tie our knots, they're on the outside of the lumen. Okay? Now, what if you placed it in there and the knots are on the inside of the lumen? I could care less. I really don't think it makes any difference. I would probably use something, in this case, like 3 or 4/0. I don't know the metric size of that. But something like PDS or Maxon. So then you pre-place those trachealis, then you tie them, then you place the sutures around the rest of the trachea, like this. And then the very last thing you do is place a suture, a ring above, go inside the lumen, come outside here, same here. So these are tension relieving sutures. So you place the suture in to bring it out, and those are the last 2 sutures you place. This is very straightforward, very easily done. It's something that can be mastered by most surgeons without any difficulty. The only difficult part of this particular procedure is preserving the blood supply and the recurrent laryngeal nerve. So those 2 things are the most important things when it comes to tracheal anastomosis. Okay, let's see where we are here.
You made a picture showing
Yep.
the recurrent then has nerve in conjunction with your trachea.
If what? If there's disease?
No. Do you have any picture during the surgery where you see the
No,
nerve?
no. We can see that. We'll show that on the dog. Yeah, it'll be easily demonstrated. It's really easy to see on the cadaver. Okay, let's see now where we are time-wise. Okay, now since we have the animal on its back, which is what we're going to be doing first, and we're going to be doing all the neck surgery. Then I thought, well, while he's on the back, why not just do one more procedure, and that is access the tympanic bulla, the middle ear. So we're going to do that. I think what I'm going to do, since there's so few of you, rather than show the video, I don't have a video of the middle ear. I have some pictures. But actually have you be at the table where the dog is going to be, where I'm going to do some dissection, but this is probably the only procedure I'm going to demonstrate. And just have you watch, because it's very simple, very straightforward. And we have all the instrumentation for it. So, okay, hold on just a minute here. I'll switch. Okay, most of the time, our indication to doing this in the dog is if we have chronic infection of the middle ear that we just cannot cure. Maybe the dog has vestibular disease or responds to antibiotics. Antibiotics has to be long-term, 4, 6, 8 weeks long. You got it? Is it out of place? You got it? You got it? Okay. So it's one of these conditions where if it's chronic and antibiotics don't help, then we have to access it. Obviously, making it the easiest way to get there and do what we need to do is the ventral approach. So middle ear, unresponsive to medical management, it may or may not have a disease of the external ear. This is probably much more indication in the cat, but the procedure in the dog is pretty similar to what it is in the cat. We have the surgical option where we could do a total ear canal ablation and lateral, but we prefer to keep it easy. If we only need to approach the middle ear, then we'd rather approach it ventrally because it's a lot easier to have, because it really is in the bulla quite nicely to access cavity, the fluid. Okay, so we know otoscopic exam. they're attached, and then of course, just plain X-rays. Here's our middle ear. The problem here is the chronicity. And the animal has vestibular. We need to access samples, and leave it. Sometimes is all we need to do out thoroughly. And approach it laterally. And it's usually done. We can palpate the ramus of the mandible. Some compartments, so remove everything, flush, and the mandible comes. Portion of the mandible. Okay, the digastricus muscle, stylohyalus muscle on this. Every anatomical landmark. And feel that nice round. And that's what you want in all your subcutaneous. Dissecting and stay right on the over into any damage, okay? Dog is extremely trying to find the bulla.
Very big. The French bulldog.
A long time. In the ventral bulla for exposes all the ear canal to be removed. Come in with the dog and extended. And feel the mandible. On the same surgery, so that's nice. A pin chuck, Simon pin. And when we talk about the muscle, this surgery, and I have no concern. Okay, so just stay and you're going to make a hole right into the bottom. Rongeurs. Then once you make the hole, large, again using take your sample, send it in for bacterial. The type of material that comes out of the bullet, it's very thick, cheesy, cottage cheese type material. You take that out with just pulling it out with a forceps, and you flush tremendously. You can see the really nice size opening there, and that's pretty much a ventral bulla. Now, one of the things that we sometimes will do is we'll actually put a Penrose drain and stuff it up in there, and leave it in for a couple of days and then pull it. Or what I like to do is remove all this stuff, flush it many, many times with saline, take my sample for bacteriological culture, and basically close it completely with no drain. So you have the option, put a drain in for a couple of days or not. We used to put a drain in all the time. Now we don't really put a drain in. Okay, so let's have.
I have a question.
Yes, of course.
What are the main symptoms for nasopharyngeal polyps in cats?
For it to be chronic, the main head tilt.
Head tilt, only head
Yeah,
tilt.
vestibular. Yeah, and it's painful. Oftentimes they don't feel like eating. They may have a fever. They don't feel like eating because oftentimes animals with bullet involvement really are painful. And you take any time you just press around the mandible or up in this area, they'll just scream out in pain. They'll have a reluctance to open their mouth because it hurts. And the head tilt, yeah. And sometimes the head tilt will go away and be a little bit better, not necessarily all the way, but you're always giving them antibiotics. And the problem is the organisms can change. You know, you might start off with a staph and maybe strep. They'll be okay, and then for some reason other organisms will form, like Enterococcus. So then you're always, once it gets to the point where they're not getting better and they're on chronic antibiotics, they'll oftentimes get better initially on antibiotics, and then it'll come back. Then you'll take your x-ray and you'll see that bulla really filled up with fluid density, soft tissue density. So it becomes chronic, and you say, you know, and what's really nice about this is once you go in and clean all that stuff out, you get way ahead of everything. You're now taking this giant step forward to get ahead of the disease, and then it enables the antibiotics that you're going to use afterwards to eventually, hopefully, just clear it completely up. Not only make them clinically better, but have the whole bacterial infection go away. Okay. Okay, this is just going to show now, when we start out, we're not going to make an incision that long, okay? We're just going to make a short incision over about the 3rd and 4th ring. So the incision would probably be 5 to 7 centimeters long, not like this. You're going to go down to the sternal-hyoidus muscle, which is the paired muscle. You can see the division right here, a small little area between those two muscles. bellies. That's where you want to continue your blunt dissection. And obviously, when you're doing this and the animal is in trouble, you're going to be doing this very quickly. And though it's important that you try to practice good technique, sometimes I just go in 2 minutes, I'm at the trachea, and it doesn't look great, but it saves the dog's life because you need to get access to the trachea. Again, this is way too big. You only need about half that size. So now we look at a tracheal ring, just make an incision between the rings. Then we quickly place our 2 sutures in the rings on either side. And then put that in a forceps. You can see here the self-retracting Gelpi retractors work really nicely here. Now you can see this has the obturator in it. It's a cuff type. The obturator is going to go inside. Makes it easier to push it through there. And again, this is a little smaller diameter than the trachea itself. Now that inner obturator comes out. So that's just putting one throw on both of those stay sutures around the trachea, okay? Just a single knot, not a knot, actually a half of a knot. So just pull it down one throw on this side, put it in a clamp. This side, now put the inside cannula in, it snaps in place. Then we're going to use this hole to suture 2 places here on the skin. The other side now is done. Then the last part of this, well, the next to last part. And again, this is where we have umbilical tape, but you can use a shoestring, a white shoestring. Works very nicely for this. Okay? Leave one end a little long. Go all the way around. Tie it to itself. That goes around the neck and holds it in place. The only other thing you would do is if your incision is too long, this one of course we make long, is to actually close the skin incision above and below. But we leave these stay sutures. We just take the clamp off and leave those sutures just dangling, okay? Because we want to be able to grab those if the dog gets in trouble, open it up, pull out the trach tube, clean it, replace it with another one, or that one after we clean it. So that's what we do with our little stay sutures, is just take the clamps off, and they're there until we take the trach tube out. Okay, so now this is the permanent tracheostomy, okay? Now this is done on the same patient, so we've taken the trach tube out. And I'm going to show you now, first I talked to you about permanent tracheostomy, but this is going to show you how we would resect, it's going to show you how the rectangular type tracheotomy, you can see it, see the shape? Yeah, we don't like that. Okay, this is what we'd, so this is no, this is yes. Ja, nicht, ja. Jawohl. Notice the shape of this? Okay, 1, 2, 3, in this case, 4 rings. Okay, now let's, I'm going to stop this just for a second. So could you give me the lights, please? I want to stop this to make a point here. Okay, now, this is very, very important. And you're going to see when I do this video that I want to do the video, keep it moving, get done quickly so it doesn't go long and you get bored and you fall asleep. But when you are, here is the edge of your skin, here is the trachea that you're suturing it to. Okay, so here's the opening up here, if you will. Okay, and you're suturing, a bad artist. I'm so bad. It's a good thing I didn't major in art. So here's the skin, and here's what I need. I'll just draw the skin. You're going to see me when I go through the skin. Just go through the skin. Go through the opening, the edge of the trachea, and then back. This is not what I want you to do. Here's what I want you to do instead. I want you to come through. I want you to start back here about 3 millimeters away from the edge of the skin. The lumen's over here. And I want you to come at an angle, a very acute angle, and then go through the trachea and then back. The reason why I want you to go through that angle is because when you go through the angle and you then pull this back, the skin goes up around and makes really good contact, okay? Instead of the skin coming down flat on the opening of the trachea, it's going to come around the edge and get better apposition. So if you will, it's what we call splitting the skin. If that's confusing to you, that's my bad, my fault. I'm trying to make, but we can show you in lab. We really want you to go through the skin at a very acute angle, then go through the edge of the trachea and back. And that then brings the skin up and around and has much better mucocutaneous apposition. Okay? And you'll see, the reason why I stopped you here is you'll see I'm just doing this quickly and it's going in, it's going straight in instead of at an angle. And it doesn't get as good an apposition. So make sure we'll show you that in the lab if we're having trouble understanding. Okay. No. Sorry. Skip the head. Let's start. Let's go back. The other thing that's not shown on this that I showed you in the picture is the sternohiatus muscle and the 2 sutures we placed to bring the sternohiatus muscle. So that we're not demonstrating here, but we can show you in the lab. Before we actually start this, we would actually take our sternohiatus muscle on either side and go with sutures from this side, dorsal to the trachea, through the sternohiatus, and then back, mattress it 2. One here to there. Then that brings the trachea out a little bit. Okay, so now we're going to make 3 or 4 ring opening, approximately 30% of the diameter. We could actually make that a little bigger. Now, the first thing we do is actually place sutures between the very thin membrane, the peritrachealis. There's some very thin tissue on the trachea. We're going to place some subcutaneous sutures to that very, very thin layer that's covering the trachea. Sometimes we'll actually use cutting needles and go into just a little bit into the trachea. Like that's still the soft tissue. But if it's a small dog, you won't find that tissue there to use. You'll have to just go in a little bit of the thickness of the trachea. Now we do this to take the tension off of our final skin sutures. And we only put about 6 or 8 of these interrupted sutures. You see they actually went through a little bit of the thickness of the trachea. That's fine. Just make sure when you place these sutures that it's not right up to where the skin's cut. We go a little bit away from it so we have room for the skin. I really like the way this comes together better than when we're suturing this, because it's got this oval tapered, really makes it easier to suture it and make it look nice. Fruity, will you see if they can take us on a break maybe 10 minutes earlier than we normally would? It's supposed to be at 10:50. Let's see if they're ready for us. We're going to finish a little early. Thank you. Now you can see when I go through the skin here, I'm going straight through at right angles. You don't want to do that. You actually want to go through a very flat plane and then come through, and then the skin will come around the edge and really come together nicely. This is actually going through the cartilage. There's no attempts to try to go around the cartilage and pick up the lining. That's impossible. It's too thin. It won't hold. You're going to get the lining with the cartilage. And again, you want to go through this skin at an angle so that it comes together much nicer than what is showing here. Now these sutures are going to come out, so any skin suture, nylon suture will be fine, very small size. See, this does not look good. You need to split the thickness of the skin so it comes around and looks much better. So we'll do that, show that in the lab part.
Ron, I have a very stupid question.
Yep.
If the dog is intubated,
Yeah, the question is, when you're doing this surgery, how do you intubate them? We actually have an endotracheal tube that goes a little smaller, goes right through. So the tube is actually going to be right there where we're working.
It's only smaller, but the tube is inside.
Yeah, but it's in place.
Okay.
Nothing different, except obviously the cuff of the tube is going to be further down. Yeah, you don't want the cuff to be there. Yes.
You did the oval resection and the square resection. That was just for demonstration.
Yes, yeah. I prefer the oval. We have fewer chances of that healing back over if we do the oval. Now remember, this is like the trach tube placement. For the first, I can't do this surgery without the animal being in my hospital at least 3 days. Because those first 3 days, there's going to be a fair amount of mucus. Again, like the trach tube, it needs to be suctioned every 4 to 6 hours. We spray the saline in, so it needs a fair amount of care. Then when they go home, the owner needs to keep that area clean around the stoma, around the new opening. Keep it clean, just with warm water and a little bit of soft cotton. They need to, in the future, keep the hair cut a little bit, okay, so this material doesn't catch. And after about 7 to 10 days, sometimes a little bit longer, you will see very little material, very little secretion coming out that opening. It decreases as time goes on. Now, obviously, these animals have a great deal of problem barking, pretty much eliminate their ability to bark, make noise, which can be a nice thing in some cases. And again, as time goes on, the better they do, the better it looks, the less care it needs. Yes?
In cats, where you said, the prognosis is very bad, can't you do that procedure instead of the temporary tracheotomy?
Well, with a permanent permanent tracheostomy in a cat, yeah, they also have really, really lots of problems. Not only the trach tube, but this one. So the trach tube has a lot of, they just produce tremendous amount of mucus and plugs. In most cats with a permanent tracheostomy, sometimes you don't have any option. You may have 20% of the cats that you do that maybe just slip by and they do okay with a permanent tracheostomy. But by and large, the vast majority of them are going to die from a plug that forms. 3 days afterwards, 3 weeks afterwards.
So what do you tell the clients? No good.
Well, you say, here's the odds. You do the same thing with that with you do other diseases, that you say, here's the prognosis, here are the problems. If you want to, I will continue and still do a permanent tracheostomy in a cat. It's your cat. But you need to understand that there's a much better chance this cat will not do well than there is that it's going to do well. So then you just put it in their hands and say, you make the decision. The risk is very, very great. Now, it's not that it isn't great in dogs, but dogs, the vast majority, do quite well. Yeah. That's a good, it's tough sometimes. What's that?
Any explanation for the difference?
No, cats just seem to have a tremendous reaction to doing anything to the trachea, and they form so much mucus, and sometimes it has blood in it, but mostly it's just this mucus plug. I don't know, they just have an increased tendency to form mucus in response to either the presence of the trach tube or doing a permanent tracheostomy.
Still want to go on a question about intubation or anesthesia.
Mm-hmm.
When there's a problem with the larynx,
Yeah.
strong larynx collapse or neoplasia, how is it before place a trachea tube then,
Mm-hmm.
or still try to go?
Well, I still try to go through the mouth,
Yeah.
unless you need good visibility of an area in the throat where you're working. Then you may want to do this,
Yeah.
even though you might be able to pass the endotracheal tube.
So you make actually 2 holes then, one for the temporarily of the
Temporary, the tube.
tube,
Mm-hmm.
and one for the permanent tracheostomy.
Yeah. But in most cases, that's a really good, most cases when you're doing a permanent tracheostomy, you're still able to put a small tube in, 95% of the time. That's a really good question. If you can't, then you don't have a choice. You got to do your, I'd probably in that case do the tracheostomy tube pretty high, and then the permanent trach a little bit lower. Yeah.
And one more question.
Yeah.
When you have to cut a bit taller, the muscle sternio
Hers, mm-hmm.
Do you sutures before you close?
No, you just leave it be. You just take those two sutures, it comes in like this, and that's all you do.
Oh.
Yeah, okay.
I have a
Question, yes.
If I want to close my tracheostomy again because my trauma is done and he's breathing.
Yeah.
How do I do it?
Your permanent one?
Yeah.
Your permanent one.
If the trauma
If you do.
maybe is
Okay.
gone and
So her question is, if you have a dog that's got a lot of trauma, and you do a permanent tracheostomy, and you decide, wow, it seems like everything up here is now better. The dog can now breathe through it. Okay? So what I would do is actually break down the tracheostomy. So free up the skin, okay? Probably cut a little bit of the skin around, free it up, and then just suture the skin. That's it. That's all you have to do. Okay, very simple. That's a good question. It might occur rarely, but it still could. That's a good question. Okay, so we'll take a break, and let's see. Come back. Shall we come back 10 minutes earlier? Yeah, 11, right? Come back at 11. Okay. Okay, coffee pause. Pause. 100 to 15. Okay, good. Okay, thank you. Okay. You can hear me in the second row without it, but what? You get excited about it as much as I do because it's such a wonderful that I have talked to several people here about in your practice in this country. On the basis of my referring they'll send the case in for purposes of they can't recognize that being laryngeal paralysis, which is good for me because it's the inability to open adequate oxygenation. Muscle, which is the only there are several intrinsic of abductors. So when there's this to open up their airway. This is two things that are really important here to help that we see related to this disease. Structure, ropey type structure here. So lose their tone. And the corniculate tubercle, anyway, the front edge process, I'll show you in just a minute, on that cartilage attaches, and when the muscle contracts, here, and the cartilage opens up, close. So when the muscle contracts. Now, from the left side of the this is a cricoid cartilage. So it's actually the very first dissection. And the thing we want to pay special okay, and in a fairly thin feel the edge of that. If it's a muscular dog or a and then the next thing is when you take this thyroid cartilage, if you're by yourself, you can use a Gelpy work fine. And the very next thing you encounter portion of the retinoid cartilage. Cartilage, which you really can't see, just shows you the thyroid and the cricoid. This is described that we break it down, but it's get to the muscle process. We'll break down the articulation. Okay, so now this is so the cricoid cartilage, this edge, the caudal edge of the cricoid, this on the retinoid, and this is the thigh. And actually feel this really thick just medial to the thyroid cricoid. So those are our three as well as the thickened area on the retinoids. So those, again, what does that muscle do? It does of the retinoid, which is up here. That front edge on both sides goes like this. Now, simulation of what shoot. Why is find it here? Here we go. of the retinoid, the muscle contracts and pulls on that muscle process. What the muscle does, and I'm going to show you the function of the muscle. Now the suture replaces it's not going to have any opening and closing. It's going to just poke. You can see, this is a very important here results in here and pull on it, and this is going to come open. Muscle, but also when we place our suture, because unfortunately if we pull it too tight, aspiration pneumonia. So when we first started suture in there and pull it down and pull it really tightly, it creates too much of an opening. That opening, especially during cause an aspiration problem. So now we just how much it opens up. Okay, that's normally what the muscle does, and that is important from me telling you. So we don't open it up too much, okay? Clinical signs. Stridor. The reception room is up front, and a dog that's severely now they pant. When they get excited and pant, they're going especially if you get them to exercise. Really bring. Now I can have many dogs that come into my practice and I won't hear that sound. So I have to get him up. He won't just be panting. Interesting is most of the time we will have an expiratory. The main thing is we're going to hear the expiratory. Then as the disease progresses, and you may hear both inspiratory and my experience has been the expiratory stridor comes first. Expiratory stridor, they start having very stamina, no longer going to hike and driveway, and they start getting tired and falling down. Where it's just an old dog, it's got arthritis and any further, but in fact it's because they lose stamina and cyanotic yet, but they're poor, and it's poor enough that while they don't have very weak, and they will walk a short distance. This is really important part of the history. When they his bark now, instead of being rougher, hoarser, raspy, some of their bark, so they'll actually have this really loud expiratory stripe. Excited, or someone comes to the door, or they exercise. Really in trouble, okay? And I'll show you why inspiratory component, why it gets. The more they work to breathe, it actually makes it become oxygen deprived in their brain. They faint, then this cycle of getting worse and worse will be relaxed, and when they wake up, they'll be more to the point where they're not struggling. Now, when we have a case come into the hospital and we can't rush him into surgery yet, then the oxygen cage and give him a tranquilizer, settle him down, and once he settles down, he's stable. If he gets excited, so we can conservatively with tranquilizers, just a yeah. So that's usually almost all. Now, the higher pitch inspiratory noise in severe cases means that when they're breathing inwardly, not only do they have stridor, but now it's higher pitch, not just it's. I had a case just recently that I've never heard quite like this, and it had a whistle on inspiration. It was so severe. It was like, it was crazy. I didn't think it was laryngeal paralysis, but it ended up being. This higher pitched inspiratory noise is better appreciated when you take the laryngoscope and put it on the larynx. This is one thing I want you to take away from this, and that is, if you have an early, what you think might be suspicious, early laryngeal paralysis, get that damn stethoscope and put it on the larynx, and you will hear sounds directly over the larynx that give you a pretty good clue that this is early. The first thing you'll hear is on inspiration, it won't be a nice, smooth breathing sound, movement. You won't hear, you'll hear, it's rougher, it's harsh. And on expiration, you'll hear the same sort of thing. As it advances, there's one more additional thing you'll hear on expiration that I'll describe to you in just a little bit. But this is so important that you auscultate this area. Any dog you suspect of upper airway disease, if you can't distinguish between trachea or laryngeal area, put your stethoscope here, and that'll really help you. Now you know if they're severe enough, you can do a auscultation of the thorax, and you'll hear referred sounds from up here, down here. You know that. If it's really bad, that's all you'll hear in the chest is referred sounds. Now this dog has both inspiratory and expiratory stridor, and it's a Labrador, so he is smelling around, getting excited because I have a little basket of dog treats, little milk bones. You'll see him. He's a lab, he's looking for food all the time. God damn it, come back. Do you have the inspiratory stridor as well? Yeah, that means it's a little more advanced. And when he was examined laryngoscopically, he had complete laryngeal paralysis. This is the kind of guy, if he gets really excited, gets really warm, is out playing frisbee, chasing sticks, could get really seriously in trouble. Okay, so the dyspnea that they have can be life-threatening. It's exaggerated, of course, by what I said: exercise, increased outside temperature, ambient temperature, excitement. And here's some of the other signs. And some of these other signs are subtle. In fact, some owners may tell you with early onset of laryngeal paralysis, you know, my dog is, now these are again, large dogs, medium to large to a giant, but mostly large, mostly Labradors, but not, I've seen laryngeal paralysis in just about every breed now, including cats, cat species, feline species. But the owner will often say, well, this is really interesting because around when he's eating, he's gagging afterwards and he's coughing a little bit, and he may have a little nasal discharge because the stuff stays in the back of the throat and he's trying to swallow, and although he doesn't have a problem swallowing, he has a problem coordinating breathing with swallowing. But this is pretty rare. This is what we're going to see, a nice soft cough and gagging, especially more so after drinking. And I've actually seen some dogs with laryngeal paralysis have aspiration pneumonia because of their disease, not because of our surgery. It's rare, but I've actually seen dogs with laryngeal paralysis have aspiration pneumonia. So we have to treat them for the aspiration pneumonia before we take them to surgery. Auscultate sounds, referred sounds, a hoarseness to the bark. I told you about the stridor. Be sure to auscultate the heart. They're going to have to really be at rest, because if they're not at rest, you're going to hear upper airway sounds. But it's really important. And auscultate the larynx, like I told you, there's a lot of information you can gain. And I'm going to show you a clip here that's a classic example of why you hear what you hear when these dogs are in trouble. And you will see when on inspiration, the opening is much smaller. So, you know the old trick where you used to blow through your thumbs, and the smaller the hole, the higher the pitch. And that's what happens here. It's a smaller opening for the oxygen to move in through. And so it begins to have a higher pitch when you auscultate it, and harsh, as I mentioned before. But this is really cool. When they get really severe, these two structures that I described, the little rope-like structures, the vocal cords or folds, get very, very relaxed. If I were to tell you ask you what a wet noodle is, would you know? A wet noodle? A wet noodle? Wet noodle. Okay, a wet noodle. It's very flaccid. It doesn't have good tone. And so you will see what happens on inspiration to those vocal cords because they're very flaccid and paralyzed. Okay, well, we told you before, mostly retrievers, but I've seen it in other dogs, including small dogs and including cats. They all benefit from the surgery that we're going to do. We diagnose it on the basis of history and clinical signs, owners telling us about loss of stamina, change in voice, the noise they make when they get excited. Our physical exam findings are important. Now we do laryngoscopy. This is so important now. This is our next step. We need to do laryngoscopy not from the standpoint of verifying and making sure that it's laryngeal paralysis. We need to do a complete oral exam. Okay? I have dogs that come in for laryngeal paralysis. Sometimes they have a tumor in their oral cavity. So we need to look at everything. I look at the soft palate. I put my finger on the soft palate. I push up. I go around the back edge of the soft palate, see if I can feel any masses in the caudal area of the nasal cavity. I look off either side. I look down into the trachea, around the trachea. So we look for other things. Then we focus on the function, the dynamics. First we look for masses or obstructive, mechanical obstructive forces or masses. Then if they're okay, we don't find any, then we have to look at the dynamics. Keep in mind, too, while I'm telling you this, when you do your examination of a brachycephalic dog, about 15% of brachycephalic dogs, when you prepare them for surgery, you can, when you look at them, do your laryngoscopic exam and go, oh, yeah. Oh, yes, the little saccules have popped. You need to the laryngeal opening. Current laryngeal dynamics of the larynx. Now it's important. A little bit light under a fall. Of ketamine and Valium. Drugs that is paralyzed. You're looking. Breathing occasionally. To put the animal evaluation, but gram, whatever, per 20 pounds. So you give that. I'm ready, I'm poised, got the tongue out, laryngoscope. It takes about 15 to 30 seconds. Movement. The actual retinoids are still not moving. Thumbs moving, maybe laterally the same. We're seeing you. You cannot decide the use of dope or propofol. However, need dopram because of the barbiturate laryngeal dynamic. So you can use it, but then you don't need dopram. Movements, and then the example. All right, let's see if we can get this to work. Okay. Here now. Not working. Okay. So the first dog is going to be normal, have normal movements. I'm going to point out some really important structures. Okay, so here's the retinoids. Here's the vocal cords here. You can see and appreciate the fact, when you see the next one, you'll appreciate the fact that these are really nice, got nice tone, have a certain amount of stiffness, tautness to them. This is the front edge of the retinoids. Okay, there's the air epiglottic fold. So in a little bit, we're going to give some dopram, and you're going to be seeing some abduction. That's what we want to see. This is normal. Nice tone, and on inspiration, these structures move laterally. They abduct, which includes these structures. Now you're going to see when these structures are paralyzed, not only do we not get this movement, but now these vocal cords start doing something really bad, okay, on inspiration. See the everted saccules here? Just a little bit eversion over here. But notice how it's moving outward. In, out, in, out, in, out, in, out. That's normal. Now what's the difference between that and the abnormal one? You see he's getting a little more vigorous now because I gave him some dopram. That's what you have to do to make sure. In, out, in, out. Now what you're going to see is the retinoid cartilage that is fixed. The retinoid cartilage is over here. This is the vocal cords. Watch what happens here now on expiration and inspiration. And I can tell you what cycle it is. This is a little bit closer in with our camera. In, out, in, out, in, out, in, out. Look on inspiration. Nothing's happening to the retinoid here. It's just staying fixed. And then look what's happening to the vocal cords. In, out, in, out. See that flutter? In, out, in, out. So on inspiration, this is undergoing what we call paradoxical movement. It's actually going in and causing the airway to be obstructed by at least 40%. In, out, in, out. And this is when these guys get in trouble because the harder they work to breathe when they're hot, overheated, exercising, or get excited, the harder they work, the more this happens, and this gets worse and worse until they finally collapse. In, out, in, out. Now notice this, the flutter. This flutter, when it gets to this point where it's that paralyzed, when you put your stethoscope up on the larynx, it is so cool. Because what you're going to hear is brrt, 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 brrt. It's actually vibrating. You can hear it actually going brrt, brrt, brrt. And what's really cool is to have this dog be excited in your room, put the stethoscope on this animal and hear this brrt, brrt, and then hand the stethoscope to the owner and let them hear it. And they're going, wow, that is cool. Oh, Dr. Bright, please do surgery. Yeah. I like to get them involved with stuff like this because they can appreciate, and I show them this, I show every one of these people this video that come in. And if any of you ever want a copy of this, my aim is not to hoard it and keep it to myself, but to share it so that you can learn from it and use it if you want. You just have to let me know. Okay, so what is the surgical objective? That is the question. The surgical objective is to approach the left side. One of the most common questions the owners will ask is, do you do the surgery inside the oral cavity? And then, of course, you say no. So, and then, again, this is another one of many diseases where I'll take the book out. I have the page. It's worn out because I go to it so often. I show the client this is what a normal larynx looks like when we're looking at it. and I show them the cartilages involved, I show them the video, then I go back to the book and I say, this is what we're going to do, okay? We're going to make an incision along the left side. This incision along the left side starts just behind the ramus of the mandible and goes cranially. Now, some of you like to do stuff through a smaller incision. The smaller you think, the cooler it is. Well, give yourself plenty of room. This incision is going to be probably 12 to 14 centimeters long. It has to be that long in order for you to do the dissection. Here's the thyroid cartilage here. Here's the cricoid. Here's the trachea. Here's the hyoid apparatus in this area. Okay, so it's real close there. So be careful. When you do your dissection, make sure you keep it over the larynx and not go up into this area. Okay, I like to actually put a little towel under him so that it exposes him a little better. The ramus of the mandible is coming along here. And we're going to make our incision pretty much here. Remember, if we go up behind the mandible, up in this area, we're going to have two large vessels that are coming here, the linguofacial and the maxillary, that then come along here and form the jugular, right? And inside that is the salivary glands, okay? Well, we're going to be behind that. So what we're going to do is usually see the linguofacial vein as part of our dissection. Not always, but if you do, you either go above it or below it, doesn't matter. Okay, so once we make our incision, what we're doing is we're aiming for the top edge of the thyroid cartilage. And once you make, in thin dogs, you could actually take your finger and go along that sharp edge and know you're over the thyroid cartilage. There's one, maybe two dogs in here where we'll be able to feel that without breaking the skin. Make the incision, go through the subcutaneous. It's like doing it's actually like doing the approach to the bulla, just blunt dissection the whole way. You're going to see in my video where I really use my fingers a lot because there's a lot of vessels there and you don't want to have blood obscuring your vision. So you're going to see me do a lot of finger dissection, go a little bit deeper, finger dissection, a little bit deeper. Then once you go one or two layers in, then I can begin to take my finger and go along and actually feel this sharp edge, this border of the thyroid. Then that's where I aim with the rest of my dissection. Once we get to the thyroid, there is a muscle that crosses over that thyroid from medial to lateral. So we're going to cut it. Now, this shows you the cutting of that. Here's the edge of the thyroid. There's not only that muscle, but inside that muscle is a really, really paper-thin layer of fascia. Now, it's really important that you go through not only the muscle, but you recognize this white fascia, okay? And you need to cut through it, or you're not going to see what you need to see. The whole idea is to actually go down, and eventually, this thyroid cartilage now is going to be rolled down out of the way. You're eventually going to go down and feel this very large articular process on the arytenoid muscle. Okay, so what we're going to do is once we cut the muscle along the thyroid, that thyroid is going to be pulled down. You can see there are some sutures here that are used to retract, or you can use your Gelpi, or you have an assistant. Now what you do is you go under the muscle as it's coming up and inserting on that muscular process. This is what it is right here. So you go under it with forceps or a pair of scissors. The very thick muscle process is right here. It's very prominent. You can easily palpate it. And we're going to cut through that muscle, just behind that muscle process. But we're going to leave a bit of the muscle because when we start doing the rest of the procedure, we have to get on the inside of this muscle process And so we want to hold that up with muscle. We don't want to put we do not want to put our thumb forceps on the cartilage itself. It'll fracture it, make it weaker, fragment it. That's why we leave just a little bit of muscle. We hold on to the muscle, not the cartilage. Okay, so then we take, we sever the muscle. So we take the muscle and we sever it. We hold on to it now with our muscle, with our thumb forceps. This shows a pair of scissors. It's actually better for me and more accurate if we use a pair of periosteal elevators, curved. The curved side is facing medially, and we just go in behind that, and there's an actual joint. The cricoid's like this. The thyroid is like this. So it's almost like a ball and socket joint, okay? And what we're doing is getting in between that, okay? With our periosteal elevator and breaking that down. So that then, here's a cricoid, here's the front edge of the cricoid. We're going to see this spot right here that was part of that articulation. And we're going to see the inside of the retinoid on the opposite side of the muscle process. And that's going to be nice and shiny. It's going to be like a little round cap. And that's where we're going to place our sutures eventually. But now we have disarticulated it. What that means is that once we place our sutures in that, because it's no longer fixed to the cricoid, and we place a suture, it's going to be able to move ever so slightly. And what happens when we pull it back? This goes out. Okay? All right? So that's what we're trying to do. Okay, again, I prefer a periosteal elevator. And be careful now that when you do this dissection, most of your dissection with periosteal elevator, you want to do just on the inside of that muscle process. You'll see this white sort of disc, and you don't want to go any further forward. You want to go dorsally and ventrally, but don't go further forward or you'll go into the pharynx and have contamination, okay, from the oral pharyngoid. We don't want that. This is actually showing now the periosteal elevator. This is the muscle process. We're actually breaking it down now. This is the small tag of muscle. The head's over here. Tail's over here. Cricoid cartilage is right here in this area. So the next step we do is we're going to place sutures. So the suture we're going to place. At one time, so we go off the back edge of the cricoid. So we take the muscle, the cricoretinoid muscle, we've cut it right here. We take the rest of this muscle and take a periosteal elevator and peel it off the cricoid cartilage so we can now see the back edge. The first suture we're going to place is on the back edge of the cricoid, and it's going to come out here. When you place this suture, we didn't think it mattered if the needle comes in and goes out here, or needle comes in and goes out here, or here. Now it's real important it comes out about right here. Not too far from the back edge of the retinoid. Here's the muscle process. So we go medial to lateral, come out, then we take the retinoids, fold it back. We can see that little white target disc that goes through there. It comes medial to lateral. Now we take that, pull it aside. Notice the thyroid cartilage is pulled down. So we take that, push it aside, then we place another. So again, I showed you this, what we're trying to accomplish. So the sutures are now in place. So the one suture is going around the back edge of the cricoid here, coming out and then going around the muscle process, and those two suture lengths are here. Then there's a second suture I put in, which not everybody does this, but I've done it for 18 years probably. I haven't changed, I never will. I like the fact that I've got a second suture and it's not going in the same direction. It's going in a different direction, but it helps fix this cartilage in a position without relying on one or two sutures that are going the same direction. So I come back here and I go from now lateral to medial. This is the thyroid cartilage. Now I let go of the thyroid cartilage. I come in about 8 millimeters to 10 millimeters from the back edge and about the same distance down from the edge, and I go through like this, around that muscle process again, same place this was put, a different hole. Then I come back like a mattress suture and about 6 to 8 millimeters apart and come out. So this we're going to tie eventually, but we tie this one first. So now we're ready to tie. So we don't place much sutures, much tension on these sutures, because if we place it too tightly, it may cut through the cartilage, it may break under too much tension, it may result in too much lateralization, and now the epiglottis covering the opening to the larynx may not be sufficient. So a slight amount of tension, not a masculine tension, not a man-type tension, just a small amount. And then we take the thiopharyngeus muscle and suture it together real quickly. Biggest postoperative concern. Okay, aspiration pneumonia. All right, and that's because of what I told you. We lateralize this, we make it somewhat eccentric. The epiglottis now, when it flips up, doesn't close this securely enough. This is actually my own dog. After it died, I did a tie back about 3 or 4 years before she died from splenic hemangiosarcoma. And so you can see how it's actually adhered and been pulled laterally. Here's the epiglottis. So if this epiglottis flips up, it covers most of it pretty well. But you can see the left side, we're looking at it now. This is the right side, this is the left side. The left side has been lateralized, symmetrical to the left.
I don't understand the second.
No. Did it once, and that's it. No. This is sort of preliminary, and if that still confuses you, then we'll do it. I'll ask. Okay. Now, what about, yes?
The effect that you get from your surgery is that the vocal cord is kind of lateralized.
The arytenoid cartilage. The arytenoid cartilage, actually, interesting enough, the arytenoid cartilage is open now, and with that, the cord gets stiffer under tension. Yeah.
So my question is, it doesn't move anymore, right?
Right. No more movement.
Why not to just go into the larynx area and do a lateral 1 or 2 sutures going inside when, you know, the mouth is wide open, and do both sides some suturing and lateralize both.
Because the incidence of aspiration pneumonia will go.
Yeah, but you do it the same, you know.
If you do both sides, it's going to make it
So one
even
side.
worse. Yeah, one side. So if you do one side, I'm not sure what you're fixing it to, because if you don't fix it to something rigid like the cricoid, then it's probably going to move. It's going to come right back to the midline. I'm not sure what you would fix it to, because it has to be fixed to something that's rigid, and the cricoid is what we fix it to. So this is real important. Post-operative care is so important. I used to take these dogs and they would get excited. They're labs, they're on narcotics for pain, and they'd get excited and they'd get dysphoria. They'd be bouncing off the cage, they'd be barking. And we'd give them a sedative, and then they would lie down and go to sleep. And all we're doing with making them sedate is letting them lie around and, I think, increase the possibility of them having some aspiration. So I have changed my protocol in the last 2 years. I actually start on an NSAID the day of surgery or a day before surgery. I send them home with carprofen for 4 or 5 more days. If, in spite of my NSAID, okay, I actually use a narcotic which is butorphanol, and butorphanol has very little negative effect on laryngeal function and gastroesophageal reflux. Remember, every drug that we give as a pre-med, can we have a light, please? Here's the stomach. Here's the esophagus. This is the lower esophageal sphincter. I don't care what narcotic you use. You can use sedative. Every one of these has a negative effect on the lower esophageal sphincter tone. That's not good. When you have dogs that are aspiration pneumonia prone, we don't want that muscle. That it's a functional muscle. It's not an anatomical muscle. It's functional. But we don't want reflux from the stomach to occur. Reflux from the stomach is very, very, very strong, has a low pH, and that's very damaging and will cause esophageal problems and eventually could cause an aspiration pneumonia. So I'm trying to use drugs that don't have any effect on this, and one of the drugs that has minimal effect but is a narcotic is butorphanol. So I'll use that only while they're in the hospital. I'll use an NSAID. That's it. I don't use any other narcotics. I don't use any sedative. But here's what happens. If they are so hyperactive and they're bouncing around the cage, I send them home same day. I have a lot of my colleagues that are doing these surgeries, and many of them now routinely, they don't even wait till these dogs become, they just go surgery in the morning, home that night, because if they get really excited, it's not good for them. We want them to be up, we want them to be active, but not crazy active. So the whole idea of keeping them not sedated and also awake, I like them standing in the cage or up on their sternum looking around, because the more they do that, the less chance they have of esophageal contents coming up and possibly they aspirate it, or gastric, even worse, contents. So I'm very, very aggressive in making sure that we don't overly sedate them. Make them active. Keep them active. I just wanted to hear that again. So, every dog, including my own, is sent home with 3 very important things to do for 1 week. All this is directed toward preventing aspiration pneumonia. That is, I have the owners sit the animal down in front of them. The owner's on a chair. They have canned dog food made into little meatballs, Swedish-sized meatballs, and they actually feed them, okay, those meatballs. And if you know labs, they generally, they bolus, they don't chew. That's good. We don't want these dogs to chew for the first week, hardly at all. The more they chew, the smaller the particles are. Those particles could get around the epiglottis and they aspirate it. So when they eat, I don't want them to chew. I don't want them just to bolus. And to do that, is encourage them, is to take them and just feed them in front of you and have them just go, boop, 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 no chewing. Because it's a lab. That's the way they eat. That's for 1 week. Water doesn't matter. Some people think you should elevate the water bowl. Other people on the ground, it's Mox Nix. You can expect for a while that these animals, after they eat, and especially after they drink, will have a little bit of gagging and a soft cough. After they eat, they'll go, and they'll sound awful sometimes, but they're just, you know, they'll get better with time. For 3 weeks, this animal now is never allowed to run, go to the door and bark as much as possible to try to prevent them that, not a run. They can walk long distances. From that point on, while they can wear a collar, we never use that collar. They're going to be changed to a halter. We have no compression on the larynx, okay? So change to a halter. So if they go for walks on a leash, it's here. They can still wear a collar, just don't use it. No, obviously no playing with other dogs. Replace the leash or use a halter when you're using a leash. Again, over time, this is really cool. They still will have a soft cough and gagging, but it gets less and less as time goes on, which is pretty cool. Exercise, again, after 3 weeks of really, really, really strict restraint. Could you be a little more obvious? Do you want to fart now, too? So, yeah. Allowing these animals to have excess exercise or barking a lot puts a lot of pressure on that suture, okay? I don't want them doing this, or running up and down with their neck going up and down, because that suture for 3 weeks, okay, really it's important until the fibrosis and scarring occur between those cartilage. So we want to really keep them quiet for 3 weeks minimum. Well, my own dog used to snore, okay? And her snoring was very similar to mine. So one night, my yellow lab usually is mom's dog. She's over on her side. So one night, the yellow lab is sleeping on my side. And so we're sleeping through the night, and all night long I'm getting this shit, you know, from my wife with the elbow in my ribs saying, turn over, quit snoring. And the next day I said, why'd you hit me so many times? You were snoring. I said, no. It was Emma. It was our yellow lab. So I was getting the blame, but the yellow lab was doing the snoring. Now, after the surgery, the snoring on the yellow lab went away. So my wife was thinking, well, maybe you should get a tie back. Maybe your snoring will go away. Okay, this is a tough question. You know, some dogs, they live to swim, they swim to live. I mean, when people come to me and go, oh, Dr. Bray, my dog loves the water and loves to swim. So, but everybody's going to tell you, don't let them swim from this point on. And my answer to them is, if this is an important part of their quality of life, I really don't think it's going to result in them having problems. And if they do, it's water, and they're going to cough it out. You know, how many times you see dogs go out in the water normally, come back, and they're coughing. They already, you know, swallowed it. So if it's really, really, really important to this dog's quality of life, I'll say, go ahead. I have had many dogs, hunting dogs, return to be good hunting dogs following this surgery. It's very, very satisfying. Okay, and over time, the chances of aspiration pneumonia become less. However, remember, this is a polyneuropathic disease. It's polyneuropathy. The background or the etiology, the etiopathogenesis of this particular disease is due to a polyneuropathy. So all nerves and skeletal muscle that's supplied by nerves is affected. It just as this paired muscle in the larynx is the first muscle that's affected in a dog. Then the next few muscles are either swallowing or regurgitation. If when a dog comes in and has laryngeal paralysis and the owner tells me that the dog regurgitates 2 or 3 times a day, or when it eats will go and really is effort at swallowing and has severe dysphagia, we have to think very, very closely about whether or not that dog should have LARPAR surgery. That dog's more susceptible to aspiration pneumonia. Luckily, 95 out of 100 dogs are going to have no concurrent signs. It's going to be relegated to the larynx. Going to be limited to the larynx. So, but these are other things that happen. This is what happened to my yellow lab. She got weaker overall because of her skeletal muscles. She never became dysphagic, and she never got this. She just had generalized weakness, and then she died of a splenic hemangiosarcoma. But it is a progressive disease, so if people talk to you about what happens if we don't do surgery, it's a horrible, horrible ending for these dogs, because it's like you drowning and suffering and gasping for breath. So it's just an awful thing to do. It's not going to get better. Anything you do medically is not going to help. It's going to require some type of surgery, okay, period. One other thing I was thinking of. I can't think of it. Oh, so for 1 week, oh yeah, I know. While they're in the hospital, besides the fact that they've been given an injectable NSAID like carprofen, I will give them metoclopramide subcutaneously and an antacid intravenously like famotidine. So I give it preoperatively while they're in the hospital. I give them injectable. They send them home, and for 1 week they'll be on an antacid like famotidine or omeprazole, and they'll also be on metoclopramide, okay, for 1 week. So they're fed in a special manner, small amounts, 3 or 4 times a day for 1 week. They're on an antacid, oral, it's fine, and on an oral metoclopramide. Here's the reason for that. Aspiration pneumonia decreases, the chances of aspiration pneumonia decrease when the stomach is as empty as possible. So that's what the metoclopramide does, is it keeps the stomach contents decreased. So it's a prokinetic, causing the stomach to empty a little bit faster. The antacid changes the pH, so it's a little bit more toward basic. So if that gastric fluid, remember, esophageal fluid is not too injurious to the lungs. It's the gastric fluid. So if we can increase pH, it's not as harmful to the lungs. Okay, so that's for just 1 week. Then after that, I change them to dry dog food, what they've been used to doing, probably kibbles. But I just have them moisten it a little bit so it's not hard, and they have to crunch on it a lot. So just wet it. Wet the dry food and feed it like that, 2 times a day. Okay. Wow. Coffee break. Okay. Pause. Then we come back. I'll do the video. Then we go in. If I have to stay here till midnight to teach this procedure to you, so that you know do it, so you can do it and feel comfortable doing it. This is a very. I'll be here till midnight. I said what? I have. Oh yeah, we're going to show it. Seriously, this is an important procedure. I hope you can learn it, and I hope you can use it. This is very satisfying, okay? And so I'm going to be real disappointed if you don't go out of here as excited as I am. And I think, now you're going to do 2 sides, okay? We've got 2 sides of the dog. So we're going to have plenty of time. So you'll do the left side first, get familiar with anatomy. Then you take your brain, you go, okay? And you do the right side, and everything's just completely opposite, okay? If you're dyslexic, you're in good shape. Okay, so you'll have plenty of time. Take your time. Dissection, we are here. We're going to show you the video. The video is going to helpfully put pretty much everything together. And then Dr. Broom will be there to help you, and I'll be out walking in the countryside. But I'll be back at midnight if you're still here. Okay, we'll take a pause, come back at 15:30. 20 minutes.
I have a question.
Oh, God.
The inversion of the laryngeal sacculae.
What?
It is often, and it can be in a
No.
with laryngeal.
That dog you saw that was normal, that I showed you an example of normal, was a brachycephalic dog.
Yes, but inversion of the.
So he had a little bit. What about him?
It is a problem that occurs very often.
No.
No.
And when it occurs now, I'm very seldom ever take him out. Seriously. If it's a really fat, obese English bulldog, and he's got this big, long, sloppy, soft palate, and he's got these big white balloon things sticking in the way, I'll take him out. Otherwise, I ignore him. I used to take him out all the time. Now I don't. Here's the reason for that.